everyone. Here is Dr.
Hi, Dr.
Shadmehr.
Shadmehr. Thank you so
Hi,
much for joining us today.
I'm happy to be here and thank you for inviting me.
Thank you. So, can you tell us a little bit about your background and where you went to dental school and how you came to be an endodontist?
Sure. So I was born and raised in Iran. I went to dental school in Iran. It was a 6 years program. And then straight I went to Endo. It was a 3 years program with master. I had my faculty, my own practice, private practice for 5 years. And then I moved to the US and then I went to 2 years program in Buffalo. So as a foreign trained dentist, when you come here, you have to redo some part of your education. Usually you have to go to 2 years program as an international dental program to get your DDS, US DDS, and then you can do specialty after that. I was so fortunate, I just went straight to endo program in Buffalo, and then I got my certificate there. Then I moved to San Francisco, and I am now full-time faculty here. I have my faculty practice for 2 days, and the rest I teach for pre-doc and postgrad students.
That sounds awesome. So, what made you decide that you wanted to pursue a career in endodontics?
So usually I think you have to choose your career based on your personality. And I think I'm a very detail-oriented person. And also I like challenges. And though I can tell whoever like challenges will enjoy it because it never ends. You never know what's going to happen inside the tooth. And you open it, it's just everyday challenges. And also, and though we're talking about 1 millimeter short, 1 millimeter long, it's all about details. And during dental school, so one of my faculty, he was always saying that you can be a good endodontist. I think he wasn't right. He was right. He wasn't wrong. So, and then he encouraged me to just think about it, and then I went to different endo practices, start shadowing, and also I started to shadow residents to see and then realize what is really endo, because the amount of the root canal that you are doing during the dental school is not enough for you to realize that is this the right fit for me or not. So if you are thinking about any specialty, I recommend everyone to just go out there, um, see, shadow residents or endodontist or orthodontist, anything that you would like to choose as a final career, and see what is the real life and see if that's the right fit for you or not. So then I start to do that and I realized that, yeah, I think I like it. And then I chose it for the second time, right? So when I came here, I chose endo for a second time. And I think if I had to choose it again, I will. So I love endo.
That's great. So, can you talk a little bit about the different endo programs that you've experienced here in the US?
Yeah, that's a great question. So here you have the opportunity to just do a 2 years program and just get your certificate. Usually people that they want to go straight to to private practice, they just take the shorter, way. Or if you want to get a master's, so you can join 3 years programs. So there are so many programs that offers both 2 years and 3 years, like my program back in Buffalo. But I just chose 2 years program because I had my master in Iran, so it was 3 years program back home. And then here also you have 5 years program opportunity if you want to do it with master. Some people, they like to do research, and also that's a very great opportunity to just do at a higher level, all about endo, and then do the get the PhD with it.
That sounds very interesting.
I can just add something else that so some programs are paid, like UCSF. There are not many out there, so I think we have only 3 programs in the whole country that are paid program, and UCSF is one of them. My program back home, in Buffalo, it had tuition, so and the tuitions are varied between different schools. But I think when it's paid, it's just more competitive. So here it's very competitive.
That seems like an important consideration when choosing programs. So, can you talk a little bit about what endodontics is?
So endo is a specialty focusing on diagnosis and treatment of the tooth, what is inside the tooth, and also mainly for treating of tooth pain. So if root canal comes up, everyone think about the pain, right? So it's kind of related. And so we have 2 different approaches, surgical and non-surgical. Usually we take the non-surgical, most conservative way, but we take pride being a specialty to save teeth. So when the cavity or caries reach to the pulp, which is the tissue inside the tooth, at that point there is no other way to save the tooth other than the root canal treatment. So if that happens and the caries reach to the pulp, basically you have two options: either extract the tooth, pull out the tooth, or save the tooth by doing a root canal. And that's why I like it. So we are the specialty to save teeth, and we're teeth savers.
Hmm. That sounds awesome. So now can you talk a little bit about your typical day in endodontics as a faculty member and as a practicing endodontist?
Yeah, so I will talk about my typical day now, and then I will compare it with the time that I was a full-time endodontist. So now I'm full-time faculty. I'm a pre-doc director at UCSF. So basically, I write a syllabus for pre-doc students that what are the requirements for them to become a dentist, and how many root canal they have to do, what are the exams, what are the C exams that they have to take, and basically run the pre-doc students to become a dentist. And also I teach post-grad residents, which they are already dentists, but they are taking these 2 years program to become an endodontist. So I teach 1.5 day for pre-doc, 1 day for post-grad, and also I have 2 days faculty practice, which I see my own patients. I start with two two consults, two treatments in the morning, and also I have my research time and admin time. So when I was a full-time practitioner as an endodontist, so I usually started at 8, finish at 5, and I used to see, I can say, 6 to 8 patients a day, and just a break at lunchtime.
That sounds great. Your schedule now sounds really busy.
Now it's more, that's why I love it. So you can I teach, I do my research, and I see my patients.
That sounds great. So now can we talk a little bit about the kinds of procedures that endodontists perform?
So as I said, we have surgical and non-surgical approaches. Usually 90% our approaches are non-surgical because it's more conservative. For non-surgical root canal treatment, I can divide it into two categories. So we have initial root canal treatment or retreatment, which is redoing a root canal that a tooth has already, a root canal treatment has been done by general dentist or another endodontist, or it's on your own case that has been failed, and then now you want to redo the root canal or take another approaches to save the tooth. So we are doing everything to just save that tooth. So 90% of our, I can say, our procedures are non-surgical. And from that 90% that are non-surgical, in my practice, I can say 70% are initial root canal treatment. That is just a tooth that the caries got into the pulp, and you need to do a root canal treatment. And 30%, 30 to 40% are retreatment, that they are already, the tooth has been treated before, and now you're redoing a root canal to either improve it, or if everything is perfect, then you are basically changing the treatment plan to surgical to save the tooth. And also we have surgical root canal treatment, which is, we call it epicoectomy, the main one, and it's 10%, about 10% of our patients are treatment. And by epicoectomy, I mean that everything looks good inside the tooth. Outside, the tooth has a very good crown. And then the only etiology that has been left is something that is outside the tooth. And we're going surgically, opening the gum, addressing the problem, which tooth, for example, which root has the problem. And also we are removing, resecting the trim limiters of the end of the root, because we believe that trim limiters has more ramification, the anatomy that we cannot address it orthograde. And also we're removing the lesion. The lesion, I mean the bone loss that happens, is full of granulation tissue. That granulation tissue can be cystic. And during the procedure, by surgery, we're removing part of the tooth, removing the whole cystic or granulation tissue inside the bone, And then usually we fill that bone, we graft the bone there because now it's an empty space, and then we're closing it. So this is one of the procedures that we're doing. We call it surgical root canal treatment or epicoectomy. Epicoectomy is just an old term for it. And the other one is root resection. For example, it's a three-rooted tooth and one of the roots has cracked. So, but we have two other roots that can keep the tooth stable inside the mouth. So basically, we're resecting that tooth, and then we're hoping that we can keep the tooth by just removing that etiology, which is just a crack root. The other treatment that I'm so excited to explain it for you guys because it just sounds so weird. And also, when I'm explaining for the patient, they say, "What?" So it's basically a last resort to just save the tooth. If you think that you are not able to do anything to improve the root canal treatment, or you are not even thinking to do the surgery because you're thinking the tooth is cracked and it's just, for example, one um, conic, I mean, it's just single rooted tooth or it's a conical shape. So we're extracting, pulling out the tooth, looking for the crack under the microscope magnification to make sure there is no crack. And if everything looks good, we are just cutting the tooth, the 3 millimeters in everything is you're doing everything in your hand. So we're cutting the end of the tooth, putting the tooth back inside the mouth, inside the socket that you're pulling that tooth out, putting it back. It should be done in only 15 minutes because the time is very important here. And then it has an 88% success rate if you're doing everything perfect. And the other one is autotransplantation. It means that basically you're extracting the tooth, you're finding it's cracked, so trash the tooth, and then if the a patient has, for example, a wisdom tooth that you can extract it easily, it's conical shape. You have to do the root canal ahead, so you have to plan everything ahead. Do the root canal for that tooth, extract it, and put it back in the socket of another tooth. So by having this is not as common as in the past because now we have implant. So autotransplantation, I'm not a big fan of it because I believe implant is better option. But for intentional implantation, if you see you have all the criteria, I think that's a very valid option to save teeth.
Okay. I've never heard of like taking a tooth out and then putting it back in before. That's really interesting.
Now you know. I think I need to log my phone. Sorry.
Okay, no problem. All right.
Okay.
Okay. So, what are some kinds of complaints that patients present with?
The main chief complaint. Let me just So usually severe. What if I make it like that?
Oh yeah, that's good.
Okay. That's good. Do you
Yeah.
see me?
Yeah, I can see you. It's good.
Okay. So the chief complaint of patients with that they need a root canal. I need to generalize it. It's not like I mean, you have to go through the diagnosis and everything. I recommend everyone to just go and watch my live with Jenny at UCSF. So I talked about the diagnosis from A to Z. How can you diagnose a tooth that needs a root canal treatment? And I think that's very informative. But if I want to make it very simple, if the tooth has severe sensitivity to cold or hot, that lingers, that's most of the time the tooth needs a root canal treatment. Or pain on bite, spontaneous pain is very important. Or pain when patients sleep, and also percussion and palpation. Like patient can say, when I tap on the tooth or when I bite on that tooth, it hurts. So these are the signs of the tooth that needs a root canal treatment. The other one, which is more obvious, is abscess. So the patient has swelling. It means that there's an infection going on there. Or sinus tract, like patient say, oh, I have a pimple here, it drains. So we need to trace that to make sure that which tooth is a problem. And most of the time, that's endo related.
Okay. So now that we've talked about some of the complaints that patients present with, what types of diagnostic tests do endodontists use?
So we have to use two tests to confirm that the tooth needs a root canal treatment. First, pulpal, which is basically we are testing the tissue inside the tooth, and periapical tests. So periapical tests are tests for outside the tooth. So for inside, a pulpal test is cold, hot, and EPT. So cold and hot are the most common. I mean, the cold and EPT are the most common one. We usually don't do hot unless the patient chief complaint is sensitive to hot. So for cold test, we usually use that spray that you can see on the screen on the right side, and just spray on the cut and pull it, put it on the buccal side of the tooth. We usually put it on the cervical part, cervical third, and always start with the normal tooth so patient can see what is the normal, what is not normal, and also you're training the patient that what do you expect from them, and also to see the pain threshold of the patient. Some patients are very sensitive, even if you touch the normal tooth, they're just jumping. So then you will realize that, okay, that's her or his normal response. And then you should ask always, is it the same as the control tooth, or is it more severe? Does it linger? So that's the main part. Always start with the normal and then compare it with the tooth that you're questioning. So with the cold, and also we can do the hot test. We usually use it with a hot bath. So place a rubber dam and then put the hot water around the tooth to just do the hot test, which is not really easy to do it. And for EPT, it's an electric test. So as you can see in the picture, it has a probe you're putting on the tooth on the buccal side, usually a occlusal third, and also it has different rates. You can play with it. Usually start with a low rate and then increase it if the patient doesn't feel it. The other test, the other tests are periapical tests. So periapical tests are percussion is always tap with your finger first. Ask the patient, do they feel it? Because some of them, if they have abscess, they are very very sensitive. If you tap it with the mirror, patient cannot tolerate, and they lose their trust. So always start with the finger, normal tooth, then compare it with the other tooth, and also if the patient didn't feel anything, then you can go with the mirror at the end of the mirror and then tap on the tooth. With the palpation, I would recommend you to start both sides, and from the back distal come on top of the tooth, and then from the mesial, ask the patient to tell you if there is any sensitive area that they feel. And also with by doing it both sides, if there's any asymmetry or discrepancy, so you can compare them together. For the bite, there is an instrument, as you can see in the picture, the white one. So it has an indentation on top of that instrument. We call it tooth sloop. So you can put it on specifically on each cusp of the tooth, and then ask the patient to bite down, hold it, and then release. Usually, if the patient has a pain on release, it means that there might be a crack on the tooth. And other instrument or test that we can confirm the crack with is transillumination. So we can put the light on one side of the tooth. If the light gets blocked in the middle of the tooth, it means that um, the tooth has a crack and that crack blocked the light. Mobility is very important. So always check the mobility with two hard instruments, because if you're using two fingers, basically you cannot feel if there is any mobility or not. So it should be either with one mirror in a finger or two mirrors. And the probing depth is very important. So probe is that instrument that we have, you can see in the picture, and we have to walk around the tooth with it between the junction of the tooth and the gingiva. It's usually within the normal limit, should be 2 or 3 millimeters. If it's more than that, it means that there is either perio problem or endo problem. And the diagnosis of between those is just a long discussion. We're not going to go through that.
Sounds good. So how has endodontics changed over time?
Endodontics change over time. So let me just. So before they used to do all hand instrumentation. So everything was with hand. Those instruments that you can see on the bottom left are hand instruments, and usually now we use them, but not as often as before. So only very small sizes we're just using them, but for larger sizes we have rotary files, so we can attach them to the handpiece, as you can see on the right lower picture. And after like finding our path with a hand instrument, we just attach the rotary instruments to the rotary, which just because it's too much work on the hand.
Mm-hmm.
So rotary helps us, and that's a big change. The other one, and then also the material that they make the file with, it was stainless steel. Stainless steel is not as flexible as NITI instruments. So today we have NITI instruments, and they also do a lot of treatment on NITI instruments to make them more flexible, but also flexible with memory shape. So we have a lot of advances in that category just for files, a lot. And then we have different files come out every year, I can say. The other thing is magnification. So before they used to just do the root canal without magnification, which is just I cannot even think about it. But nowadays we use microscopes. So with microscope, we use a lot of magnification to just find the canal. Some of the canals are very calcified. You cannot see without microscope. And the best one is the scan. So scan is very new, and we usually scan these days because of so many variation in anatomies. So basically, endo was, I can say, it was kind of blind, and you go there and just get surprised. But CBCT and magnification, everything helps you to not to get surprised. So you are planning ahead, and you know what's going on before opening the tooth, which is a big, I think, improvement. Especially scan is, yeah, I love scan. So I scan like 90% of my cases.
Oh, okay. So now can we talk about some of the new, oh, sorry, do you hear an echo?
Oh, no, no, everything is
Okay,
good.
sorry.
Yeah.
So now can we talk about some of the new technologies in endodontics?
Yeah, so technology is just it keeps going, it just every day, everything you hear about new things that helps endo. And for example, different CBCT machines. So we have now Morita, Carestream. Every day they just come up with different technologies. The most important thing is guided access preparation, like Navident. So we have different kinds. This is just one of them that you can see on the right side. It makes the root canal like a game. So you're aiming for it, and then just you have to just stay with the target. It's helpful because sometimes the tooth is completely calcified. It means that it's completely blocked. So no matter what you do, you have to drill through the tooth. And then tooth doesn't have that much room. So if you go wrong, you can perforate it or extra opening inside the tooth. And then so many times perforation happens in the very like up. The prognosis of the treatment drops a lot. So this Navident basically it plans everything, and then you are drilling through the whole tooth to basically make a canal or to reach to the point deeper and deeper to find the canal. And it's really helpful. The other one is irrigation activation. So nowadays we are emphasizing on irrigation because the whole point is just to reduce the load of bacteria inside the canal. So the whole point is to clean and shape inside the tooth and then feel it. So this gentle wave thing that you can see
Mm-hmm.
is only one of the samples of irrigation activation. So basically, you're opening the tooth and attaching that handpiece on top, and by attaching that handpiece on top, it just it's like washing machine, just clean inside the tooth that you instrumented, like kind of open canals. And now this is just washing inside the tooth with sodium hypochlorite, which is bleach. And then we are bleaching inside the tooth, make sure everything is clean before filling it with the filling material.
Okay, that sounds very interesting.
Mm-hmm.
So now I have a question for you. What do you think dental students should do if they want to get into an endodontics residency? And I know a lot of people watching are pre-dental students, but as Dr. Shadmehr discussed with me earlier, we think that pre-dental is a little early to be planning for endodontics, but you can still start thinking about what you can do in dental school. So,
Exactly. So, I mean, let me talk it in general first. So,
mhm,
you want to choose the like in dentistry, right, as your career. I would say the most important thing you have to think that is this a right fit for me or not? Do you do you know what are the pros and cons as being a dentist? And then I remember everyone telling me that, oh, it's just it's you will get neck pain, back pain, and but I think you have to just go out there, watch like not even one day, like 1 week of general dentist or endodontist. What is the real life of this job, and see do you really like it or not? And some people they don't like to talk to too many people. Really, it's just you have to be able to talk to people. Like if you want
mhm,
to become an orthodontist. And the good thing about endo, you don't need to talk too much because you're placing a rubber dam and then patient cannot talk.
mhm,
I like it, but as a dentist, as an orthodontist especially, you have to talk with like at least 80 per people a day, and that's a lot. So just shadow the endo resident, shadow faculty, shadow anyone, endodontist or any a dentist that you see. Just go and see what is the real life of your future. And then also, okay, you want now you know that you want to get to dental school or you want to be an endodontist, then work on your resume. So for resume, I can say you have to for endo especially if you want to choose any program, you have to know what is the program that you're applying. For example, UCSF is a research-based program. If you don't have any research, you don't have any like chance to get into this program because if we are teaching you to become an endodontist because the program is a research-based, we expect the resident that's coming they do some research, right? To just put
mhm,
your the name of UCSF out there, just present the cases, present their research, right? So work on the resume based on the program. But for example, there's a program that's not research based, so if they want experience, so they don't accept anyone just right after school. So if you graduate like now, you cannot apply for that program because they want you to do AGD, like Advanced Educated General Dentistry program, or they want you to do GPR, or you have to practice outside for 2 or 3 years, which most of the program for, especially for endo, they need that because endo is difficult, and if you don't like it, you're gonna hate your life because it's so detail oriented. As I said, we're talking about the details. You have to be very patient. The procedure is long. Each treatment takes at least half an hour to up to 2 hours, sometimes two or three sessions. You have to see the patient, and it's uh, yeah, it is challenging. So you need to um, have experience. I mean, by doing or how many root canals can you do like during dental school? It's just maximum three, four, five, or even 10. It's not enough. You have to work outside, get experience, see the real life, see if you like to endo or, and also make sure that this is the right fit for you. That's my best advice to for even dental pre dental students.
mhm. I agree. I think experience is really important to get to know how it's going to be in the future.
Exactly.
So you touched a little bit on this, but what are some tips you wish someone had shared with you when you were a pre-dental student?
Yeah. So as I said, I knew that it's just physically straining on your neck and back, but that's real. When they was telling me, I said, "Yeah, I think I'm good. I'm gonna go to the gym. I will work out." Probably it's a lot. Like I don't have like 10 years experience, but I have neck pain, back pain, which I'm young. I consider myself as a young dentist or
Mhm,
endodontist, but I feel it. So then I have to keep myself active, do a lot of workout, keep my back and neck like strong, but um, it's real. If someone has something like from, I don't want to discourage anyone, But if you have like something like back or neck problem, maybe this is not the right career for you because you're gonna suffer. You will have this pain forever, and this will add up to all the strains of your physical strain that you have already. And this is something that you should consider, that you are sitting for mainly our job is just sitting, and then you, especially for endodontists, because you're freezing yourself for using a microscope. We're doing everything under the microscope. So if you freeze yourself like a whole day, and it's just a lot of pressure on your back and neck. Um, so I would say exactly. So the same thing, just shadow, see if this is a real thing for you. Do you really like it or not? And before I forget, like DAT is important, DAT score, so you have to improve that because there are so many small things that just can stand you out from other applicants. We have a lot of applicants, so I'm in the admission committee too, and but like you see like a lot of applications come through for dental school. So you have to do a lot of things to show that you are good with your hands. Also, like for dental school, if you're a good painter or you show that okay you have talents and you have skills with your hands, basically I can see that okay you're a good you can carve a tooth because dentistry is art and science. You have to be an artist to be able to just carve a tooth as a general dentist, which is
Mm-hmm.
really important. And also, I see that, for example, those dental students that I'm working with, if they had experience as a dental assistant or hygienist, I can see their difference because they know what is a real life. They have experience before that, and they're ready when they're here. They know what is the flow of like work. They know more instruments. So those are really important. If you, for example, this year you don't think that you can get in or you don't have anything like a resume, don't get discouraged, or you applied before you couldn't get into dental program, just go work as a hygienist or dental assistant. This really helps you, first of all, to make sure that you like it. The second thing is you will see the real life. You will learn for all these instruments. There's a lot of things to learn, and the name of these instruments, how do they work, when do you need them, and I think that's the best thing that you could do.
That's very good advice. Thank you, Dr. Shadmehr.
You're welcome.
So now I'm sure everyone's wondering how the COVID-19 pandemic has affected you practicing endodontics.
Well, that's a good question. So, pandemic. First of all, we have fewer patients. So, and also the process that we have to see patients, I'm not sure about other schools, but I can talk about the UCSF and in dental, for dental students, for postgrad, and for faculty. So, for all of them. We are not seeing any patient unless they have the COVID test result negative. And this will talks a lot. So because it slows down everything, the patient should come in. Even if they have an emergency, we're just prescribing antibiotic to stable the patient, but then we have to send the patient for COVID test. If it's negative, the patient can come and get an appointment. So the whole process and then to get the results, it was faster earlier, but then we have a lot of patients now, so it takes at least 3 to 4 days to get the result, and then the patient can make a schedule. So basically now dental students, I think they can just see 3 to 5 patients per week, if I'm not wrong. And then everything is the flow of patients are lower. The other thing is infection control. The whole infection control is different. We have to wear a lot of PPE, N95 mask, shield. We're covering the whole microscope with the shield, so there is like a partition between me and my patient. And so more PPE, more time to set up the room, to break down the room. So these are something that takes the procedures takes it gets time, right? So everything is
Mm-hmm.
just slowed down during this time.
Mm-hmm. It's like a new normal.
Yep, it's gonna be a new normal.
So now we were hoping you could go through a few cases and tell us what's going on in these x-rays.
Okay, let's talk about it. All right. So actually, this is a case that there's something happening. So pre-op X-ray, you can see the tooth in the middle. The tooth had the crown before, and the crown fell off. So general dentist send a patient to me asking for, do you think we need to do a root canal before going and putting a new crown? Because any time that you do the crown prep, basically you're removing tooth structure, and then tooth had already why in the first place the crown fell off, right? So it fell off because of the caries. So
So it's
caries,
this one, right? This crown fell off.
I don't see you. Can you
Oh,
believe?
okay. I meant
Show,
like the tooth on the left side.
let me see. Just no, go on top. Pre-op. Do you see the pre-op one?
Oh, sorry, I was looking at post-op. Okay, so
Yes.
this one in the
Okay.
middle.
This one in the middle, exactly.
Okay, I see. Thank you.
You're welcome. So that one, so we need to, that basically I said, if you want to crown prep it again and remove all the caries, we will hit the pulp. So at this point, it's better to do a root canal before going the root canal, before going placing crown, new crown. So I was doing the root canal and see what happened. I said bypass, broken file. So I broke one of the files inside the crown. So this is one of the things that's very common. It will happen. And if it happens, basically you're adding a lot of time to your treatment. So you have to bypass that file or remove it from the tooth. So removing, we can do it if if the broken instrument is a little bit higher or more accessible. But these instruments um, fracture separated at the very, very end. And it was in the last minute that I was ready to upgrade the tooth. If you see, I upgraded the mesiobuccal root. Sorry, I should just say two other roots. So it has three roots. So I finished all the other two, and I was ready to finish the third one. And I fit the cone, which is the filling material. But then I said, oh, I need to go 1 millimeter longer. So then I put the file separated, and I said, okay, now I have to deal with it. This is the real life of endodontist. So nothing always goes smoothly. So then little by little, you have to use hand instrument to just bypass, go around the file that has been broken, and then at the end you place your filling material. And my final result is perfect because I cannot even see that broken instrument anymore. So this is one of the non-surgical approaches. And then I fill the crown, inside the crown, and then send the patient back for getting a new crown.
Okay, that's cool. So for the second one here, we have a video.
So this is one of the cases that root canal has been done by another endodontist, and then there was a mesiobuccal canal. I mean, one of the canals has been missed. But then because I saw in the scan that everything is calcified, we planned for surgery. By surgery, as you can see, we open the gum, find the tooth. I use the dye to color to find the missed MB2, which is the fourth canal. And then I use tiny instrument. This is ultrasound to retro prep that canal. So I found the canal, retro prep. I'm removing, basically, this is the canal, as you can see. Two. So one of them, see, it's now empty space. I remove one part of the filling material, and now I'm filling it with another different material, and then make everything flashing, like clean. Then I place bone grafts here to fill the empty space, cover it with the membrane to make sure the healing will happen, and that's the end result.
Wow.
And the follow-up and everything is just looks perfect.
Oh, look at the end, sorry. Okay, yeah, that looks awesome.
Thank you.
So it seems like we still have about 15 minutes until the end of the session. So if Isa could look into the live chat and see if we have any questions. Did any questions come up?
Let me see.
Or meanwhile, while you're looking for questions, Dr. Shadmehr, do you want to look at your Instagram page maybe to look for another case?
So the
Exactly.
first,
I
oh my bad. Sorry.
We'll just do one more case, then we'll go to questions.
yeah.
Okay.
Let's go to my page so I can pull up one of the interesting surgery cases. Maybe go down. Widows are usually surgery, so go down, please. Oh, you know what? Let me show you the intentional implantation,
Oh
which is
yeah.
the one extracting the tooth, putting it back. Yeah. Let's see. Which one was? Go up, please. Up. Uh-huh. Up. More. It says intention. Oh, after. Oh, we can see. It says vertical. Go up. Go up. No, no, no.
This one?
My. Yes, that's the one. Yes. So vertical root fracture, mesial root. So these tooth. So one of the roots I knew before going there that most probably the tooth is cracked. Then I extract the tooth so you can see the crack line in my hand. This is a tooth in my hand.
Oh.
And go on the right side. Can you go in the second one? So play. Now by finding the crack line, then I decided to just cut that part and just chase the crack to see how deep is the crack going. And then we ended up removing the whole, resecting the whole root because the crack was just going deep and deep. So I resected the whole root, as you can see here. This is one of my students actually record this when I was doing. And then you have to resect 3 millimeters of other roots. Can go to the next again. So see, you can see other roots because the main part is the 3 millimeters is always a problem. As you can see the filling material, the pink thing is inside, and then there is a like fine line around it. It means that none of the canals are just round. So you have a space which is usually a narrow space. It can be ribbon shape. It can be just like a line, as you can see here. And it's hard to clean and shape all the smooth and the ramification in this area. So that's why when we are doing a retrograde or doing the surgery or with intentional implantation, basically we can see and then feel it more properly than orthograde. Can go to the next one. Yeah, see, it's more clear now. Next one. Just then I'm using the ultrasound and also burr to clean out that all the isthmuses here. Go to the next one. Yeah, I'm just making it smooth before filling it. Next one. Now this is a filling material that is very biocompatible, so body can tolerate and grow bone around it. So I filled all the retro prep cavities with this BC sealer and BC putty and put the tooth back. Go to the next one, I think. Yeah, that's it. So it's a filling. I cleaned the whole thing before putting the tooth back. I don't think I recorded the putting the tooth back, but basically you have to just find which is like a puzzle, which side you should put the tooth back. Yeah.
Hey, that's really cool.
Because
I've never heard of that before.
Yeah.
All right, Isa, what you got?
Okay, so the first question we got was aside from the neck back pain that you mentioned, what are some of the challenges that you face on your career?
Uh, Other challenges. So, good communication with patients. So it's sometimes, especially these days, especially in San Francisco. So we have a lot of tech people, so they Google everything, and you and they are very educated. So you have to explain everything, and sometimes before they trust you, like, like most of the time that what you're saying, but these days you have to talk a lot, and to just come sometimes because patient when comes they don't have any pain, but you see the problem there, so you have to explain and that convince them that they need a root canal treatment. To I think you should be a good communicator. If you are not an extrovert or in you cannot. I think it's um, hard for you to make connection with different people, especially other specialties like ortho. You should be very a good communicator. You should say, "Wow, look at you! Look at your teeth! Like you look beautiful." These are real things. So and I think mainly is just the physical straining. Is I think I can say that that's the main challenge. The rest, if you really like dentistry, really like endo, you can survive. The cases are really challenging these days. So compared to before, because now the oral hygiene is higher, so you don't see really like their patients, the age of the patients that are they need a root canal is higher now, and then when they get older the tooth become calcified and canals are closer, so you need more instrument, more equipment to just do the treatment. So the treatment for a root canal treatment for a like 20 years old patient is super easy. I can say for me now it's super easy compared to like my patients 80 something, so it's more challenging. And you need to spend more time, and also when they get older they have more medical issues like heart problem, then you have to know what time. For example, today I had a patient with seizure, the other patient had like high blood pressure, so these are my routine life. But then if it was like before, because the oral health wasn't that high, so you could get more young patients, no medical issue, everything was healthy, the tooth are just young, it's easy to do root canal. So those are main challenges, I think.
Thank you, thank
Very
you.
interesting.
So, what would you say is the most important part of the application? The shadowing, the GPA, or the DTA score?
All of them, you cannot say which one is more important. You are basically you're seeing the application as a whole thing. So I'm not saying, oh, I'm just going to check the AT, I will just skip the shadowing. Everything is important.
I agree, I agree. Um, what is something that you wish that you learned in dental school before you started as a dentist or endodontist?
I think I was a good student. I really spent time, like I was dedicated to the whole thing. So yeah, I think I was a nerd. So I didn't do anything to say, oh, I wish I did. I
You're
did
just
more.
studying the whole time.
Yeah, yeah, I did everything right.
What is your favorite endo procedure to perform?
My favorite, I really like surgery. So we're not, as I said, it's just 10% of our, maybe because we are not doing it like that much, but epicoectomy, the surgery part, I really enjoy. And I think that's why my page, if you go back, I have a lot of surgery cases that I present and I do video of them. I really enjoy doing surgery. Yeah.
Thank you. Where is the procedures different from when you used to practice in Iran versus now that you practice in the United States?
That's a very good question because I get that a lot too. So I can compare like most of the things were the same, but the only thing I didn't have CBCT that back home. So and now that's why I'm obsessed about it because I think it makes the root canal way easier, or you're prepared when you go there, you know what's going on. So but the main thing like the instruments that we were using is almost the same. I had a very nice practice, so I had everything except CBCT. And I think patients were younger, you know, so that's why here I think I need more to take more scans because patients are older. And yeah, that's the only difference.
So would you say it's easier here than Iran with the new
But
technologies?
because so technology here helps. That's why I have older patients, but because I have a scan and better technology, so it makes it easier. But over there I didn't have CBCT, so but the patients were younger, so it can come to
It
six.
balances out, exactly. So how do you think, oh, this is, what is the name of the first procedure that you performed in case number one?
What was the name? Oh, my patient, my first patient
Procedure.
The procedure that you perform.
in dental school or
In
here?
this case one here.
Oh, the case one here. It's a just initial root canal treatment, and then because the instruments separated, I mean we can say bypass the file, so it's just a root canal treatment. Yeah.
What are some tips and things that you regret not doing as a pre-dental student that you wish that would have helped you throughout your career?
I think I answered that one right.
How do you deal with rude patients or patients who do not want to undergo certain procedures?
They don't want to go under some certain procedures.
Yeah, exactly.
Yeah, I that's the challenge. So always I do my best to explain, but if the patient really doesn't want to, never ever push anyone to do anything. And I never like to go some, you just do your job, explain everything the best that you can and document everything for sure because sometimes patients doesn't want to get the root canal. Like if you remember, there was a time that last 2 years there was a show on documentary on Netflix called it was the name was Root Cause, and that show caused us a lot of troubles because the documentary was completely biased. And then the AAE, American Association of Endodontics, they put a lot of effort to just take out that show because it was a lot of wrong information. So saying that root canal can cause cancer, breast cancer. So I had a patient coming out to me and say, okay, what if this procedure caused me the breast cancer? So then you have to go through a lot to explain all those things that this is not true, this is not wrong, but then you have to let them decide, right? And then some people they don't want to um,
Change
accept,
their
right?
opinion. Yeah.
Exactly. So then what can you do? Just document everything that you explain. They know that they need a root canal. If the infection happen or anything happens, basically you just protecting yourself because you cannot convince everyone to just accept your opinion, right?
Mm, that's a good point.
Thank you, thank you. What are the conditions that a tooth must have to be reimplanted after performing an apectomy?
What? Sorry.
Okay, I guess we'll just skip that question. What is an experience that really solidified your decision to be an endodontist?
uh, I think yeah, I think one my faculty who encouraged me, he really knew me and he watched me, and also that basically started the point that oh, okay, I think this is something that I may spend more time to realize that I do I like it if I'm good at it. So then I went to shadow residence. I started with the postgrad residence, and then I went to shadow him actually when he was doing a root canal treatment. Say, hey, you're telling me this is good. Let me see how do you work. What is your real life? I was in his practice like every day as a dental student, and then I work on my resume. And then because I was dental student in the same school, so I got into the same program, and they knew me. So I think that helped because they knew my work, and my GPA and everything was high. So yeah.
Alrighty, I think that'll be the last question since it's 10, and also we're a little lagging, so it's probably even past 10 by the time you guys see this. But thank you guys so much for attending the session, and thank you so much, Dr. Shadmehr, for being our guest speaker today.
Thank you for
You all,
and I
yeah,
hope so that you get. I think that's a great idea to do shadowing like that. And I would say that, yeah, you should get all these specialties, talk with them. And then during the COVID, I know you guys cannot go and shadow that much, but I think this will gives you a really good opportunity. Talk with a 1 hour with each specialty would help a lot because I think in fact in the practice you don't get that as much time to talking about the details and the
mhm.
showcases because you have like in real life you have patients, you cannot really spend a lot of time with the shadowers. So I think this is a very good idea. It's a great idea, and then I'm really proud of you guys doing this.
Thank you,
Thank
thank you.
you.
Yeah.
Thank you for
Also,
coming,
guys,
honestly.
follow Dr. Shadmehr's Instagram. As you guys saw, she has some really cool cases and explanations. So be sure to follow her. And
And don't
Isa is
hesitate
gonna.
to ask me. Yeah, don't hesitate to ask me if you had any question. Happy to help. And have a good
Thank
night.
you. Have
I'm
a
gonna
good
be
night.
posting the Google the docs for the questions, so you guys need to answer that if you want to receive credit.
Yes. So